Now, our next presentation, bear with me, is a video presentation which I've been reassured everything will work fine. So, as my therapist says, you know, just make the best of it. However, Dr. Karlitz is an outstanding young gastroenterologist who's at Tulane. We're very fortunate to have his involvement in these issues. Now, Jordan's specific contribution is, you know, Rebecca Siegel's been able to educate us based on the SEER and RESULT national CDC NCI cancer databases. So that's very, very helpful. But if you want to go in there and try and learn more about young adult colorectal cancer, you're stuck. You can't find anything about family health history information. You can't find anything about BMI directly associated with the patient. You know, there are a lot of limitations. But there's a very concerted effort, and the CDC is trying its very best to step it up in terms of the amount of data that's included, particularly with regard to molecular markers, including MSI status. This is extremely important because we don't have this information, and we need to have it. So I'm just going to take a deep breath, and I'm going to trust that Dr. Karlitz's video will come through loud and clear because he's doing terrific work. Let's all cross our fingers for Dr. Karlitz.
Hi, so I'm Jordan Karlitz, and the title of my talk is Utilization of CDC Comparative Effectiveness Research Data to Assess Lynch Syndrome Screening Practices in Surgical Management in Early Onset Colorectal Cancer. And I just want to show how grateful I am for being invited to give this talk at this wonderful conference, and I'm definitely sorry that I couldn't be here in person, but just to place a photo to the name, that's me. Standing in our medical school lobby. So these are my disclosures. And the objectives of the talk are really twofold. The first thing I want to do is review the details of CDC comparative effectiveness research data sets. And really, the reason we want to do this is because we want to see if there could be a potential utility to using this data in the understanding of early onset colorectal cancer. And then I want to provide you with a concrete example of how I use CER data to understand population-based Lynch syndrome screening and surgical management practices in a Louisiana population. And this really serves to highlight the granular or detailed nature of the CER data set. So just to kind of delve in and review the CER data set, so the first thing we want to do is define comparative effectiveness research. And so this is defined by the CDC as the generation and synthesis of evidence that compares the benefits and harms of alternative methods to prevent, diagnose, treat, and monitor a clinical condition or improve the delivery of care. So funding for the CDC CER project was provided for data collection in 2011 only, so people definitely need to be aware of that. And what happened was the CDC used the funding to establish 10 specialized registries within the NPCR to participate in the CER project. So there were 10 states, or eight full states, and then parts of California and Florida. And there were 4 cancers that were focused on, including breast, colon, rectum, and chronic myeloid leukemia. And I should highlight that CER is the largest and most comprehensive data collection effort by population-based registries in the United States. So that really attests to the power of this information. So the key about CER data is its enhanced data collection compared to what usual registries collect. So there's information on cancer treatment, for example, surgery, detailed information on chemotherapy. Importantly, there's information on biomarkers such as KRAS, microsatellite instability testing. And then there's information on height, weight, and smoking status, so that could be potentially helpful in the study of early onset colorectal cancer. Detailed information on comorbidities, insurance coverage, income level, et cetera. There are a number of variables that are looked at in this data set. So the training for the CER collection process was provided by the CDC to state registries and registry abstractors. And the process is really quite standardized, which makes it homogeneous across the different registries participating. So local hospital registrars and central registry abstractors collected data and fed it back to the state registry. And with regard to the central registry abstractors, they actually directly visited facilities to obtain the information, so that's important. And it should be mentioned that the data was collected not just from hospitals, but from out-of-state hospital sites as well. So that includes surgical centers, physician offices, et cetera. So it's really a detailed collection process. So just to give you an overview of the number of patients studied, there are about 75,000 total cancer patients studied during this initiative. About 64% were breast cancer patients, 24% colon cancer, 9.5% rectal cancer, and 1.4% CML patients. For colon cancer cases specifically, there were about 18,000, and there were about 7,000 rectal cancer patients. And when you look at early onset patients, there are about 1,700 colon cancer patients and about 1,049 rectal cancer patients. So now I want to switch gears and talk a little bit about how I was able to use the CER data set to understand colon cancer in Louisiana, one of the states participating in the CER project. So just to introduce colorectal cancer in Louisiana to everybody, we have very high rates here. It's one of the highest incidence rates populations in the United States. And we actually have a very focal area of increased risk in the Acadian population of southern Louisiana, which I've been studying for the past few years and published an epidemiology study a few years back showing that in the Cajun population, the rates are some of the highest in the United States. And so the leading hypothesis here is that there may be a founder effect for Lynch syndrome in this population, although that has not been proven yet, and we have grant funding underway to study this population. So what I wanted to do is I actually wanted to use the CER data set utilizing biomarkers, MSI and IHC, test results to try and figure out if there is a higher or a signal for a higher hereditary burden in the Acadian region. So obviously, MSI and IHC data is not going to definitively tell you if somebody has Lynch syndrome, but it could provide some clues. So just to give background on Lynch very briefly, about 1 in 300 people in the US are mutation carriers, many undiagnosed, which may amount to over 1 million people. It's autosomal dominant with a very high lifetime risk for colorectal cancer. That may be a bit high, but one study showed this. And then tumor testing on colorectal cancer specimens with MSI and or immunohistochemistry testing is often the first step in the diagnostic process. So when we tried to figure out if there were large numbers of abnormal test results in this Acadian region, unfortunately we found out that the testing rates were so low across the state that we really couldn't make any determination of whether there was an increased signal for abnormal biomarkers for MSI and IHC in this population. But I figured that because the testing rates were so low, it might be a great opportunity to actually use the CER data set to study population-based testing practices in Louisiana, really focusing on quality of care. So we ended up publishing this paper a few years back in the American Journal of Gastroenterology, where we looked at underutilization of Lynch syndrome screening with MSI and IHC. So we used as I've already alluded to, we used the CDC CER biomarker data set collected by the Louisiana Tumor Registry to look at early onset testing in early onset patients. And this was really the first population-based study examining Lynch syndrome screening practices in the United States. So we had detailed CER information on about 274 patients, 50 and under in Louisiana, that were diagnosed with colorectal cancer in 2011. Again, 2011 is the year of the CER data set. We had information at 61 distinct healthcare facilities throughout the state, so this is really a true population-based study. And we found out the Lynch syndrome screening rate with MSI and or IHC was only 23%, and as we all know, that really should be 100%, particularly in an early onset population. And when we did multivariable analysis, we found that the testing rate was very, very low in the public hospital system, only about 6.5%, and in rural areas, it was only 12.3%. So this really provided important information on how people are screening young patients for Lynch syndrome, and unfortunately showed major deficiencies in testing. So an important thing about the MSI and IHC testing results was that through the CER data set, we were able to tell if MSI and IHC was ordered on a colonoscopy or a surgical resection specimen. So this was really interesting because preoperative testing on colonoscopy biopsy specimens as opposed to a colorectal cancer surgical resection specimen could help guide germline testing decisions and extent of colonic resection. And as we know, there are high rates of metachronous colorectal cancer and Lynch syndrome if segmental resection is performed. So following from this, if MSI or IHC is done on surgical resection specimens, results will only return after the operation has taken place. So you won't really be in the position to have germline test results and have a risk-benefit discussion with the patient about extent of surgery. So we really wanted to look at the timing of MSI and IHC testing. And what we found was that the results were available preoperatively in only 16.9% of cases. And there are really two things driving that. Number one is testing rates on colonoscopy specimens, on the preoperative colonoscopy specimens, were very low. It was only ordered 34.9% of the time. And even if it was done on the colonoscopy specimens, many patients went to the operating room without waiting for the results to return. And then importantly, most of the time, the MSI or IHC was ordered on the surgical resection specimen, which obviously the patient has already gone to the OR to get that resection specimen, so the results won't be known until after the operation is over. This is just a slide showing that we were, through the central registry, we were actually able to obtain all of the IHC results that the patients had. So these are the 8 patients that had abnormal IHC, and through the data set, we had information on pretty much everything, which just shows you how detailed the information could get. And out of the 8 patients with abnormal IHC, 7 had a pattern that would potentially be consistent with Lynch syndrome, obviously needing to be confirmed with germline testing, however. And we did not have information on germline testing through the CER data set because that was not one of the variables that was part of the CER data collection project. So we took this one step further, and we wanted to see what percent of the patients in the state ended up undergoing extended colonic resection. So we published this in Clinical and Translational Gastroenterology a few years ago. And we looked at the same early onset cohort in Louisiana, and we found out that only 6.8% underwent extended colonic resection, and that ECR, not surprisingly, or extended colonic resection, was not associated with abnormal MSI and or IHC test results. And the reason for that, implied from the prior study, was that abnormal test results most commonly become available postoperatively. So we don't know the potential risk for Lynch syndrome preoperatively. It should be noted that extended colonic resection was actually associated with polyposis, meaning 10 or more adenomas. That's how we defined it, or in age, or age less than 45. So I do want to spend just a minute talking about how we ended up using the CER data to do another study. So it was really a jumping off point to try and understand what is happening nationally. So we used the CER data set in Louisiana to do population-based studies on adequacy of Lynch syndrome testing, but we really wanted to take this to the next level and try and figure out what is going on nationally. And so we did a survey study through the American College of Gastroenterology, really looking at barriers to the ordering of MSI and or IHC testing. So we sent the survey out through the American College of Gastroenterology, and we had about 5,786 confirmed recipients of the questionnaire, which was an electronic questionnaire. 509 people took the survey, and we had a response rate of 8.7%, which wasn't terrible, but not great, but kind of not surprising given the detailed nature of the topic. And what we found is that some of the most important barriers to ordering MSI and or IHC were cost of testing, unfamiliarity interpreting results, and unavailable genetic counseling. And we found that most of these barriers clustered in non-academic and rural settings. So that was an interesting finding. We also asked the question to the survey respondents, which were pretty much all gastroenterologists, who they thought should be ordering MSI and or IHC testing. So should it be the GI doctor themselves? Should it be pathologists? Should it be oncologist, surgeon, et cetera? And what we found is that there was just kind of a wide spread of what GI doctors said. Most of them, well, most felt that the pathologist should be responsible. The second most common response was that GI doctors themselves should be responsible, but then they also felt that the surgeon may be responsible sometimes, or the medical oncologist, or a geneticist. And so we term this diffusion of responsibility, meaning that one person thinks another person is ordering the tests, and that other person thinks someone else is ordering the tests. And what ends up happening is the testing just does not get done. So to conclude, I just wanted to kind of take you guys on the journey that of how I used CER data. So if you remember, we used CER data initially to identify this high-risk Acadian population, and where we have a concern for a founder effect for Lynch syndrome in the population. And then we used CER data to see if we'd be able to look for a signal for abnormal microsatellite instability in that population. But unfortunately, as we discussed, we found out that the testing rates were so low that we couldn't really tell much of anything about this population through the CER data project. But we did end up switching gears and doing a quality of care project using the CER data set, and we were able to understand Lynch syndrome management practices in terms of MSI testing rates, which we found were very low, and also we're able to assess surgical management. So this was very detailed information that we were able to look at on a population-based level, which is a real strength of the CER data set. And we could potentially use data like this to understand early onset colorectal cancer. So as I mentioned previously, we have 2011 data on about 2,700 colorectal cancer patients under age 50 with detailed information on smoking, obesity rates, insurance status, et cetera. So hopefully we'll be able to take advantage of that going forward. And again, I want to thank, I'm very grateful for being invited to speak today, and I'm sorry I couldn't be here in person, but if anyone has any questions, they can always email me or call me. Thank you.
So I just want to underscore that Jordan has really been a national leader in this arena. And, even when the news isn't good, we need to know, right? So you can see the lack of unity of command with regard to ordering MSI testing. You can see that if clinicians are not taking responsibility, if hospitals don't take responsibility, if healthcare systems don't take responsibility for issuing guidelines on exactly who should be tested for what and when, you don't make a lot of progress. But Jordan has made tremendous progress and has really advanced the CDC's efforts to increase the amount of information we have as we try and study young adult colorectal cancer.